Good morning, everyone. My name is Nira Tandon. Oh, we have a callback. Good morning, everyone. My name is Nira Tandon, and I'm president of the Center for American Progress, and I am truly thrilled to welcome all of you to this really critical conversation. We are here to discuss what is nothing short of a national crisis confronting millions of Black mothers and children across every segment of our society. What is happening today in our country truly is an outrage. Black mothers are 243% more likely to die from pregnancy or childbirth related complications than white mothers, while African American infants are nearly 250% more likely to die before their first birthdays when compared to white children. That is unacceptable. The terrible reality is that Black women are suffering at vastly disproportionate rates, regardless of their income, their level of education, or their social status. In fact, a high income Black woman with an advanced degree is still more likely to die or experience the death of her young child than a poor white woman who has never graduated from high school. Think about that. Over the past 2 years, Black women have acted as an indispensable pillar in the resistance against this administration and have done so much to protect progress. And if progressives are truly committed to expanding equality and justice for all Americans, then we must take immediate action to end the rampant discrimination, deprivation, and neglect currently facing Black mothers. At CAP, we believe that we are uniquely positioned within the think tank community to help shape a multifaceted progressive response to this crisis. And I'd like to thank the Irving Harris Foundation for supporting CAP's work to address maternal and infant mortality and help with this event today. We're drawing upon the knowledge of experts throughout this organization, including staff members who focus on the issue of healthcare policy, racial justice, early childhood education, and women's health and rights. Today, as part of our continued mission, we're honored to host a lineup of incredible panelists who are bringing this vital issue to the forefront of our national consciousness. We look forward to hearing from their insights in just a few minutes, but first I have the true privilege of introducing our next speaker for this morning's program, Senator Kamala Harris of California. Senator Harris stands as a tireless champion on behalf of American women and their families. She has been fearless in defending people who have been under attack by this administration from day one. It's really been an incredible honor to see her as she has done so much. And recently, she introduced the Maternal Care Access and Reducing Emergencies CARE Act in the Senate, which is aimed at reducing racial disparities in maternal mortality and morbidity. And we're so grateful, really, truly grateful, that she can join us to share why this issue is so close to her heart. It is my great honor to welcome to the podium Senator Kamala Harris. Please give her a warm welcome.
Thank you, Nara, always, for always being a courageous and fearless fighter and always being on the vanguard, identifying the issues that we must address and taking them on head on as a leader in our country. I really appreciate you and thank you. Good morning, everyone. Good morning. So, as you were talking, Nara, it occurred to me that this is one of those truths that must be spoken. This issue of maternal health care, and in particular, how it relates and affects Black women. This is one of those truths that must be spoken. We live in a world and in a society today where a lot of people are rightly extremely distrustful of their government and its institutions and leaders. And the nature of a relationship of trust is such that it's a reciprocal relationship. You give and you receive trust. And one of the most important ingredients in any relationship of trust is that we speak truth, uncomfortable though it may be. Because if we're going to actually address what must be dealt with, we must speak those truths. And when we speak them, it is not with the aim of shocking or offending or making people uncomfortable. This is a truth we must speak so we can deal with it. So it is a truth that we will speak that black women in America are 3 to 4 times more likely to die than white women because they choose to become mothers and want to raise those children to be productive members of society. That is a truth. Uncomfortable though it may make us, it is a truth that must be spoken so we can deal with it. And so that's part of why we're here today. We're here today to speak these truths so we can elevate the conversation and so that we can share this information with all those who need to know it, and I believe would want to know it and do want to know it, so we can address the problem and deal with it, because this is something we could actually solve. We could solve for this, because at its core, one of the biggest parts of the problem is that this is an issue that's about race. This is an issue that's about race. And this is an issue that is also about implicit bias as part of the problem. And so what we have done is we have attempted in one way to be part of the solution, and that is the piece of legislation that I've sponsored, which would essentially acknowledge the implicit bias that is behind part of this problem and do what we can to create incentives for medical schools to teach the issue, and do what we can to actually document and research the problem, and also create pilots within the states where we will address the issue and give resources to states to work with community-based organizations, to work with the moms who are at risk of this kind of bias. And I'll tell you, for me, this issue is personal. So many of you know my mother was a scientist. She was a breast cancer researcher. And my mother had 2 goals in her life: to raise her 2 daughters and to end breast cancer. And she would come home mad, just angry sometimes, talking about the inequities around scientific research and the delivery of health care as it relates to women. And and so as a child, I became aware of and learned that these disparities exist. I remember one time she came home, she was just livid. And I'm going to share this with you, and I don't mean to shock you, but it is a vivid story I'm about to tell you. But she was absolutely outraged because she worked in a lab, and she was one of the very few women, much less women of color. And she came home and she talked about how she was walking through the halls, and there was a doctor walking around with a plate basically, and on it was a breast. Because there was a woman who just had a mastectomy. So uncovered on this tray, basically, walking around with this breast. Now, she said, and I think, I don't mean to offend anyone or shock anyone, I wonder if it had been a penis, would he have been walking around that way? Yeah. Right? Because it showed a lack of understanding about the dignity of a woman's body and the need to treat it with dignity. And so it sounds like an extreme example, but it is an example of what we need to do to understand that women in the healthcare system must be given dignity. They must be listened to. They must be taken seriously. They must be given respect. They must be given a sense of dignity about understanding that when they tell you something, listen. When they tell you what they need, listen. They know what they need when they tell you. Hear them. And so that's a lot of what's behind this issue. And you know the statistics and why we have so much work to do. When the United States is one of 13 countries in the world where the rates of pregnancy-related illness and death are worse than they were 25 years ago, we know we have work to do. Worse than 25 years ago. When we've seen a nearly 27% increase in maternal mortality rates from 2000 to 2014, we know we have work to do. When black women, again, are 3 to 4 times likely more likely to die because of childbirth or pregnancy-related complications than white women, we know we have more work to do. And so one of the steps that we are taking is our Maternal Care Act, and as I've described, we will fund implicit bias training. The bill starts with a $25 million competitive grant that is being offered to medical schools and nursing schools and other health programs to support the training in implicit bias. We are also directing, as part of this legislation, that the National Academy of Medicine will study and then recommend incorporating bias recognition testing for medical schools. And third, we will establish through this bill a demonstration project, taking off of great success that was actually achieved in North Carolina on this subject, to do what's called a pregnancy medical home program. And essentially, as I mentioned earlier, it will encourage states to actually work with community-based folks to make sure that we are creating a safe and welcoming place for these moms, for these women, to actually talk about their concerns and their needs, and then also receive the treatment that they need. And so I'll just say in conclusion this. In addition to that, we also designated April, a week in April, as Black Maternal Health Week. And it's nice to know that we can actually have an opportunity to use that week to heighten awareness, but frankly, that's not enough. It needs to be all year round. And so that will be a part of it. But the bottom line is this. This is something that we can actually solve for. And it is something that communities know that they are experiencing. And it is time that we at the national level recognize and acknowledge it, and then handle it and deal with it. And so I'm very excited about what you're doing at CAP to lead that conversation. And my final point then is this. I've found myself saying recently that if something's worth fighting for, it's a fight worth having. If something's worth fighting for, it's a fight worth having. And when it comes to maternal health care for Black women in America, it's a fight worth having. And so this is what we're doing today. And I thank you all the warriors in the room. Thank you.
Thank you, Senator Harris. Good morning. So we're going to bring up our panel now for the discussion. I'm Jamila Taylor. I'm a senior fellow with the Women's Health and Rights team here at the Center for American Progress. Great. So we're going to get right into the conversation. I do want to be mindful of time, and we have a great group of women here on the panel to get into the details on this issue. I'm going to start off by introducing them. I'll note here that you do have access to their full bios on the table in the back with materials. And as Nira mentioned earlier, we have also at CAP been working on this issue over the last year or so, and we have several materials and products available for you to review. So again, be sure to pick those up on the back table as well. Before I get started, I also wanted to add our Twitter handles. I'm sure you all are tweeting, or at least I hope you are. Senator Harris definitely gave us some gems. So the hashtags are hashtag maternal justice, hashtags Black Mamas Matter, and hashtag think babies. Okay. So sitting next to me here, we have the beautiful and wonderful Dr. Myra Jones-Taylor, who is with 0 to 3. She's a chief policy officer with the organization. Sitting next to her, we have Jenny Joseph with Common Sense Childbirth, and also creator of the JJ Way. Next to Jenny, we have Brianna Lipscomb with the Center for Reproductive Rights. Next to Brianna, we have Nina Martin, a reporter with ProPublica. And then at the end, we have Dr. Nana Mataba. So I wanted to get the conversation started this morning to focus a little bit on what we've seen in some of the stories that have been elevated in the media about maternal health. A lot of what we've seen is that Black women's experiences have been really hurtful to read about. We've shared, whether firsthand in terms of from women or even from their families, that they have been in situations where they have not been listened to when they've shared with their medical providers that they're feeling pain or discomfort in the birth process or even in the postpartum period. Research also shows that this tends to happen more to women of color, particularly Black women, than it does to white women. So my question to you all is, why do you think this happens? Whoever wants to start and jump in. Jenny?
Happens because it can. I think we have, unfortunately, a culture inside of maternal health that has a condoning of that's all right. Institutionally, provider led acceptance of we have to keep the machine running, and maternal health care, maternity care is a machine. It's a business. We are working under the constraints of capitalism, and women fall to the side in general, but women of color in particular suffer under that.
I think it's also excuse me, continue to happen because it's been largely unseen. I think that it's really only been very recently that women have felt empowered to tell their stories about much of their lives and their experiences. And I think maternal health has been very much relegated to the spaces of, we talk about this in private, we talk about this on Facebook, in closed Facebook groups. It's not been treated as something that they could talk about in public. And when they have, they've been often, especially women of color, demeaned and stigmatized for their experiences instead of listened to.
And I'll add, since Senator Harris told us to tell the truth, can you hear me? There we go. Senator Harris told us to tell the truth and call it for what it is. I think that we can't talk about it without thinking about the historical traumas that Black women have faced, that the institution of slavery and the impact that that has had just on the devaluing of Black bodies and the pervasive discrimination and bias that has resulted in how Black women are treated in the medical institution today. So I think that we can't talk about Black women not being listened to without thinking about the institutionalized systems of discrimination and bias that prevent our providers from listening to Black women.
And in that, Brianna, you mentioned racism and the fact that, the historical foundations of that in this country, sort of brings us to this moment we are now where we are seeing, such high rates of maternal mortality among Black women. Can you just share a little bit more about what those historical foundations are and what they look like? I mean, people are familiar that we had, that slavery is an issue for this country, right? But people may not be familiar with the study of obstetrics and gynecology in the context of that, and how basically enslaved women did not have reproductive freedom and how they were manipulated in a lot of ways in terms of their reproduction. So could you talk a little bit more about that?
Sure, you named it just there. I mean, when you think about just from the beginning, Black women being sold, being used to breed property for their owners, the structure of the Black family from the start not being valued, with moms being separated from their children, Black women providing care and providing nourishment for children that were not their own through breastfeeding, often at the expense of not being able to do the same for their own children. As you mentioned, the institution of slavery and how it really opened the door for a lot of medical mistreatment and experimentation on Black bodies. And then we also have other examples, that the Tuskegee experiments. We know about Henrietta Lacks. I mean, there are numerous historical examples of trauma that have been put upon Black people, and we still feel that today, and we still see that in how we receive care today.
Great, thank you. Jenny?
That I think that we have a version, a different iteration, but of the same thing, like a modern day way of continuation from the same processes, the medical trials, from the social determinants of health that maintain the inequities. And so, again, I just want to use that term sanctioned, condoned, accepted. There isn't outrage around that. And then, in particular, in terms of reproductive health, we do not see the connections, and so there is no outrage either.
And some people may be listening into this conversation and say, you know, well, these women have health insurance. We're, living in the age of the ACA, where we know that maternity care is one of the essential health benefits, is covered at no cost. But as you're sitting here talking about this, we also have to come to the realization that health insurance is not enough. So particularly for Brianna and Jenny, can you talk a little bit about the challenges that Black women face in accessing maternity care?
Well, I mean, I think first we have to think about access in broader terms. So access is not just having health insurance.
Right.
Access also relates to the quality of care that is delivered and received. And so so I'm not a provider, I will say that, but in some of the human rights reports that we've done within the Center for Reproductive Rights, one of which called Reproductive Injustice, we talked to women about the care that they were receiving, and you had numerous women talking about how when they did present for care, they went and they were able to geographically or physically access care. Immediately they felt judged because they may have been on Medicaid. Many women said that they didn't understand what was going on with their bodies. It was never explained to them. Another woman talked about how in follow-up care, no one called to see if she was doing okay. She had a C-section. She had wound care that no one was really concerned about whether or not if she healed properly. And so, so when we talk about just the care that women are receiving, we have to think outside of just the medical protocols that are in place and what is really going on and how are we treating women when they come in. And so I think that as we talk about expanding access to care, we have to be intentional about saying that we're expanding access to quality care and then holding systems accountable to make sure that that is the care they're delivering.
Yes, I totally agree. One of the most important things to consider when we talk about access is that it really means that the fact that there's a policy or that there's a building or even very capable and competent providers right there, you can't always get past the front desk. Access stops at the door. So we put these structures, these provisions in place, but that doesn't mean anything if you can't navigate and negotiate your way through, do these bureaucratic hurdles and handstands to get to that access. And I think as far as insurance, it's really important to point out whether you have Medicaid or you have commercial insurance. Both are miserable nightmares, and you can barely get a provider. So if we don't stay in reality around what access truly means, then we're doing a lot of work in a vacuum. And the women that are shut out are the women that constitute these statistics. The women that get in, make it through, the women that have agency, they're doing a little bit better. But they're still not getting and receiving the quality and the culturally congruent care that they need. Hence, this is why we're in this mess.
You wanted to add?
Yeah, I think it's really important when you're talking about Medicaid to remember that in states that don't have Medicaid expansion, pregnant women only are only entitled to Medicaid when they're pregnant. And many states don't have presumptive eligibility, which means that they have to prove that they're entitled before they actually are allowed to get care. And then their coverage only lasts for around 2 months after they give birth. So they're really limited in terms of the period of time that they see doctors, and there's no opportunity for many women to address preventive, to sort of take care of their health, chronic conditions, get preventive care, do family planning, et cetera, beforehand, or treat the kinds of later stage postpartum pregnancy complications that we now realize are leading causes of maternal death and severe morbidity.
So Jenny, tell us a little bit more about the JJ Way and the work that you're doing at Common Sense Childbirth. I think in the context of the conversation around insurance and how we know that, there are also options outside of, hospital or traditional settings? And how are you working to sort of fill the gap and make sure that women have access to quality care, outside of the healthcare system?
Well, I'm a midwife, British trained, and I'm suffering from the National Health Service. I've been here 30 years and been unable to get that out of my system. Like, I don't know any other way to provide care. So one of the first things that we did as we built our clinics was to make it a, what I call easy access. It's an easy access clinic, meaning you do not have a barrier to getting started. If you can't get into care, you can't be helped, you can't be triaged, you can't be supported. So we opened up first with the birthing center, but we've expanded that into clinics for women who don't necessarily want a natural birth or a midwife, who actually just want prenatal care, right? And we've offered that you can get seen regardless of who you are, what you have, which card you're carrying, how much money. None of those things are of any interest to us at the beginning, because until we can sit down with you and understand your individual situation, we really can't help you. Everything else is disingenuous, because we're saying we're here for you, but actually you can't have it, right? So access for us was that we opened up no barrier, nothing, no impediment to you starting your prenatal care. From there, we could figure out where you best belonged. Whether you needed high-risk care right away, we could make that introduction. You can't just bump up and go to high-risk care. There's no such thing. You must be referred by a physician. Like Nina said, you can't get your Medicaid without proof that you're pregnant, because you could be pretending, right? So you have to get that Medicaid proof of pregnancy letter, but you have to get it from a provider. But remember, you can't get to a provider because you haven't got any insurance or you haven't got the money. So we found that the easiest approach was to go ahead and say, just come on. You belong, you're pregnant, you're asking to be seen, let's go. From there, we can then help you get on Medicaid quicker, because we know how to do it. We took on that, it was our responsibility. We also know and have made connections within our community, which physicians will take you on, which perinatologists will see you, which hospitals. And we've worked in concert with them. So our connections are with our other providers and agencies. And we've run interference for real, rather than this lip service of, well, go over here, they'll help you. You don't actually know that. So we've tried to fill gaps, and we've found that women, once they feel they're safe, they thrive. Our statistics literally eradicated prematurity, low birth weight, and morbidity for the women in our care. The same women that, again, are populating the statistics that we're talking about today. If something as simple as saying, yes, please, come on in, sit down, wipe your tears, we're here, which doesn't actually cost any money, is that effective? Not in dropping a couple of points on the list, but actually eradicating prematurity. Prematurity, that's a $50,000 bill per baby. I just cannot understand how hard it is to just embrace open access, easy access to the systems that are there to support and provide care for you. So we found that this works. We have been able to replicate our work. We have studies that have proven our outcomes. And I really encourage all of us to start thinking outside the box. This is a matter of life and death. I don't know what we've got to wait for.
When you say open access, you mean, accepting patients, regardless of the ability to pay.
Yes,
Mm-hmm.
absolutely. And of course, we try to find ways to get them insured, covered, etc., because we do want to get paid. We're actually trying to make a living here. But at the end of the day, we get you started such that you can then find your best path. And we also find that we're saving money on so many fronts, millions of dollars being saved because the baby stays in the belly. So that's what we're up to.
Can you talk a little bit about, your care model, how you center your patients, not only in the context of making sure that they get access or looped into insurance, but also in terms of the birth work that you do. How has your model, been beneficial, particularly to women of color?
One of the things is that we realized that the level of provider did not need to be highly credentialed or expensive. We have trained and supported women from our communities to become childbirth educators, doulas, lactation educators, medical assistants. I run my practice with a team of paraprofessionals And we found that the patients actually relate better and are more comfortable, will disclose, are more compliant when they work with women who look like them, who are from their communities, who understand them, who do not judge them. So we found that it was important to not only lift up the patients, the women and families themselves, but also the providers. And we are very diverse. We run a clinic in Spanish, we run a clinic in Portuguese, we run a Haitian Creole clinic, and we have an English language clinic. But we found that the women themselves relate better to our staff who are more in tune and more culturally congruent with them than the higher end, high credentialed, very expensive practitioners. So it's a midwifery model, which is a person centered, family centered, equity based model.
Thank you. And so now that we sort of have the context of, insurance coverage, getting women into care that is, culturally sensitive and that centers them, I want to shift things to Myra and ask, Myra, once a family is ready to return home with a new baby, what do they need in terms of, transitioning from the hospital or healthcare setting that they're in to home?
So, a few things. First, they need a home. And when we're thinking about the status, the state of American families right now, and families that are overburdened and under-resourced, it is very scary to be an infant or toddler in this country in many communities. While the poverty numbers that came out recently, while poverty was decreased for most populations in this country, the only group for whom it actually increased was children under the age of 3. And why that's important in this conversation is we know that the age group that you are most likely to be homeless, so I said home, is if you are 1 or younger. So when we're talking about bringing babies home in the first place, they need a place to go, right? They need a place where basic necessities are provided. So that's one, making sure that we have economic stability for the families for when they have a child and can bring that child home. Second, it's really important for a parent to have time to bond with her baby. We need a national, a federal paid family and medical leave program for this country. It is critical that parents have time to bond. We know in terms of early childhood development, in terms of all the things that we know about brain development, that is those synapses that are forming are going to form if there are strong, secure attachment between the child and caregiver, child and parent. And if a mother is going back to work within 10 days of having childbirth, which we know statistically 25% of American women in this country go back to work within 10 days of having their child. That is not, those synapses are not being formed in the way that we know is best for that child and for the mother. So that's 2. So basic necessities at home, paid family medical leave, and then once a family when a parent is going back to work, knowing that they can take their child to a high quality, safe, early learning environment that is nurturing, that is culturally sensitive, that it recognizes the power, the strength of the family. And so that making sure that the child is then able to thrive. And in the event that a child has a complex medical need, has developmental delays, that there is a high quality caregiver who can identify that and make sure that the child will then get the support that he or she needs so that we don't have these tragic infant mortality outcomes.
And so your organization is working at this issue largely focused on infants, but you're also, with the sort of policy, proposals that you laid out, even with the 3 things that families need, you also talk about paid family leave, which is important for moms too. So how does your organization engage on these issues, not only practically, I think, from advocacy, but also from a policy perspective?
So at 0 to 3, we have a policy framework, and it's very simple. We want infants and toddlers to have good health, strong families, and positive early learning experiences. And so that's critical for child development. What I think is so important for this conversation here and why I really want to thank you and thank CAP is for bringing this conversation around maternal mortality and infant mortality together. While I think it's so important, I've been in this room a few times now talking about the racial disparities in maternal mortality, and I think we need to carve out and reserve and hold that space to have those conversations explicitly around racial disparities and maternal mortality, it is also important to bring those two conversations together to show the intersectionality of racial disparities in maternal mortality and infant mortality. Because if a mother loses her child, that is devastating for that mother. If a child loses her mother, that's also devastating, and the ramifications are long-lasting for the families and communities from which they come. But not only that, the policy solutions are interconnected, right? So if we're talking about Medicaid expansion, for example, we know if you were to do an overlay of infant mortality, maternal mortality across Medicaid expansion states and where Medicaid is available, you will see that the worst numbers around mortality for infants and for maternal mortality is a direct connection between those states that have Medicaid and Medicaid expansion. And so just for example, there was a report that came out in the American Journal of Public Health back in April that showed that infant mortality decreased in communities in states where there was Medicaid expansion, and it went down a little bit in communities where they didn't have expansion, but the disparities were particularly large and frightening for infant mortality. So the same can be said for maternal mortality, right? So the policy solutions are also intertwined and connected. So I really want to thank you for that.
Thank you. So I want to bring the conversation back to racism and implicit bias for all of my panelists here. And we heard about Senator Harris's bill, which I should also add was also introduced in the House by Representative Alma Adams. And just wanted to talk through, what can we do about this issue? One of the things that Senator Harris's bill does is to call for more training in implicit bias. So as we think through solutions, what should that training look like? What are some of the solutions around this? Because I think we're talking a lot about this issue and we know how it manifests, but I think as a country, as a system, we're still grappling with how to see real change in this area. So I pose that to the full panel. Anyone want to start? Nana, why don't you start us off? And in your answer, you could also share a little bit about how you see bias manifest in the NICU.
I'm a neonatologist at Northwestern, so I take care of premature babies and term babies with complex medical surgical problems. And the fact that healthcare providers have implicit bias shouldn't be surprising, but it was completely shocking when I first realized it, because as healthcare providers, we think we treat everybody equally and want to do the best for everyone. But of course, bias exists, and I think the first step was for me to become aware of it, and with my coworkers talk about, hey, do you think we treat families differently? And there's subtle and not so subtle ways that we treat families differently, and there's evidence now coming out that these lead to different baby outcomes as well from the NICU in terms of going home with breastfeeding, hospital-acquired infection rates, things that shouldn't be different according to races, but they are different. So we have started a educational program for the pediatric residents that are coming through the NICU rotation, and just talking about what they see, what they experienced in their 4 weeks in the NICU. And there's interesting themes that come out. They're much younger, they're in their mid-20s, so they have been exposed to the concept of implicit bias, whereas me and people of my years of experience, the concept of implicit bias is at first quite offensive, and I've had people walk out when I've talked about this because we don't do that now. No, it's just not possible. But these residents have heard of it through high school, college. Medical schools are beginning to have formalized lectures on implicit bias, but ours is just a forum to sort of talk it out. What did you see? And I don't know that there is a solution, but just I think the first step is to be aware. And I've been to lectures where they talk about, just think about, try to form a connection with the families instead of judging them as neglectful families that can't visit the babies because of transportation, childcare, employment issues, and try to understand what it took them to get to the NICU that particular day. So.
Have you seen any trainings that have, it sounds like the first step is to acknowledge and recognize that it's there. But in your work, have you seen any trainings that have been useful in helping to move providers along in this space?
I've heard of some simulation programs where they sort of enact a charged situation and how do you handle those situations. But I don't know that there's still a good grasp on how to tackle implicit bias in medicine.
Anything else other folks want to add on this piece?
So I echo what you're saying, that I think there are tools out there to assess the existence of implicit bias, but there's a great need for trainings that institutions can use to actually address it. The other thing that I wanted to mention was the need to diversify the workforce. That right now, particularly speaking from the maternal perspective, that I think only about 7% of OBGYNs are Black or identify as Black. And that's a problem when women don't see themselves represented in the providers of their care. And then I think the other piece to that is that we have to diversify our concept of the care team. So to Jenny's point, that it's not just the high-paid provider, the OB. It could be a midwife. It can be a lactation consultant. It can be a doula, or any other community health worker or paraprofessional that is providing care to a woman. And until we take that approach, then we have no checks and balances in place for that implicit bias for the care that's provided.
One of the things about implicit bias that's really pernicious is that it's kind of baked into medical education.
Right.
People are doctors, nurses, caregivers are trained in stereotypes. If these factors are present, then you jump to this conclusion, and so that's for everybody. And then you add race on top of that. And so it's really, that's one of the really reasons that it's really difficult to eradicate and to address. But so essential to address. The other reason I think is really important thing is to recognize a couple of things. One thing that hospitals and providers can do is just to kind of check themselves, is actually to try to look at their own data. I was speaking to a researcher recently who was talking about in her hospital, which is very attentive to racial disparities, really on the forefront of trying to do something about it. They started looking at their charts about when they would go in to talk to women about breastfeeding. And what they discovered is that just based there in the information in their own charts, they could see that Black mothers, that they always waited longer. And that was clear data in their own charts that was powerful and wasn't about someplace else, it was about them. Finally, the last thing about implicit bias that's really important is to understand that the impact that it has, not just on care during pregnancy, but afterwards. Pregnant women who have experienced disrespect and bias during prenatal period are much less likely to go back to their doctors for themselves in the postpartum period. They will go for their babies, they will not go for themselves, and that's really dangerous.
I would just add, I think in the early childhood field, there are, again, this is resonant about who you're actually having show up, home visitors, and thinking about home visitors who can be incredibly attentive and responsive to the needs of a family, come from the community, from what, again, similarly to what Jenny was saying, and there is that connection where you don't feel the shame. You're not afraid to ask these questions because you're going to be judged, and it's a different responsibility. I will say this, though, we have the same challenge in the early childhood field, the lack of diversity. So even though the early childhood, early care and education providers maybe historically it has been a place where women of color in particular have been welcome because of historical racism and all kinds of other things, lack of job opportunity, as we are thinking about professionalizing the workforce, there has been a whitening of the workforce. And then members of the leadership. I'm often the only woman of color who is at the national conversation and forms of leadership. And so having these conversations there about what it means to work with a family who may be at risk of having adverse childhood experiences, may have infant mortality, higher rates of risk factors for infant mortality, and not blaming, not assuming that if a parent wants to co-sleep, as although we talk about that's safe sleep is very important, but understand why a family wants to do that first before telling them why that's wrong. And then you can, building trust, building that relationship will have a positive impact on those risk factors when it comes to infant mortality. It's so critical to have folks who come to these communities with the same level of respect.
I'd like to add as far as that, with the training, that we are really, I think we're charged with training from a perspective of understanding who already knows the answers and being trained by those people. That the key to the training is that we already have our experts. So we can help in terms of really getting the message across. The other piece is that I think everybody needs the training. So the hospital risk managers need the training. The administrators need the training. Everybody needs the training, otherwise we continue our siloed approach to our biggest problems. And we can then, really open up why it makes sense to elevate Black women into positions of leadership, or why it makes sense to have trainers who do anti-racism training while you're doing your implicit bias training.
Thank you for that. I'll also add, too, that in the context of this conversation, the importance of support for community-based organizations. A lot of these organizations are women of color led. They're supporting women and families in their communities that look just like them. A lot of times they're operating on shoestring budgets to do this work. So I think in the context of the policy discussion and in terms of what's needed, we also need to be advocating for additional funding and support for those organizations as well. I want to shift things a little bit and talk to Nina about the great work that she has done with the Lost Mothers series that was produced by ProPublica and NPR this year. So Nina, tell us a little bit about some of the lessons you learned in the process of your reporting and story collection. This series was really a game changer in terms of the conversation and the dialogue around maternal mortality in this country. And so share a little bit more about your experience.
Thanks. First of all, shout out and profound thanks to my partners in reporting and editing this project. So Renee Montaigne at NPR, Adriana Gallardo, and Annie Waldman, and our editors at ProPublica, the design, everybody, all of it was incredibly important. And also the many experts and researchers that we spoke to, patient advocates, but especially women, because I think that our project really started with talking to women, and I think that has been transformational for me personally. I think for our understanding of this topic, and also I hope for medicine. I think that I'm seeing and feeling that this has been part of a maternal health Me Too moment that. And it's been really important in pushing along the kind of legislation that's been happening at the state level and even in Congress. Who knew that could happen? So for me, I think that the things that were really there's the general, and then there's sort of the disparity related. I think that the first really shocking thing to me was to realize the extent to which we don't listen to mothers. We don't pay any attention. Not experts. Health professionals were not talking to women themselves. They have all kinds of rules about privacy and IRBs and so forth, and how they conduct research. And so all of their research was largely based, shockingly based on de-identified data from things like maternal mortality review reports, if they happen to exist, or hospital discharge data, those kinds of things that don't tell you anything. They basically tell you the kinds of things that you can de-identify for. So you know the race, you know how obese a woman was, you know how many vaginal pregnancies she had, you know her age, you know the kind of insurance she had, but you don't know really the circumstances of her life and her health. And those stories and those backstories are absolutely critical to really understanding the true extent and the true cost, not just in terms of lives lost or lives damaged, but also financial costs, emotional costs, long-term health costs of maternal mortality and severe morbidity. So that was the first thing. The second thing it was to discover that we have a system that has over time really come to prioritize the health of mothers over that of babies and fetuses over that of women and mothers. And we sort of know about that in the abortion context, but the extent to which that has permeated maternal health has been really, really important. And it's true that infant mortality is and preterm birth. Those are the preterm birth is the biggest long life-threatening complication, right, of pregnancy. But we weren't paying attention to mothers, and so that's really why we focused on that. And then to discover that there were all these complications. Nearly 50,000 women a year nearly dying every year, and yet hospitals were very often unprepared for obstetric emergencies, basic obstetric emergencies like hypertension and hemorrhages and infections, things that kill people along the way. The last part, though, that's been, I think, really important is the discovery is really thinking about the postpartum period. When we think about maternal health, we always think about the prenatal period, right? And then we think about childbirth and, whether it's a good one or a bad one. And then, maybe it's complicated. Hopefully it's not. And then a woman goes home and we just kind of forget. And doctors have said over and over again, they've acknowledged that the baby is the candy, the mom is the wrapper. Once the the baby's out of the candy's out of the wrapper, we don't care. And understanding what that really means and the risks and the consequences of that has been really important to.
What was one of the most compelling stories that you have uncovered in the work so far?
I think the one of the most compelling stories was the story of Shalon Irving, who was a CDC researcher, an African-American woman, a brilliant woman, who studied racial disparities in maternal care during her very amazing career. And we found her story, as we found many of the stories, on GoFundMe. And because another thing we discovered was that maternal deaths were really not reported, even in public spaces, because they were sort of considered to be private tragedies. And so so Shalon Irving died in Atlanta. She was a researcher, and her death, there was an obituary, but that's all there was, and her obituary didn't mention her cause of death. Shalon's story was remarkable. She died. She was a remarkable person from a remarkable family, devoted to making the world better for women and families, and to eradicating racial disparities in health. She had a wonderful family, a wonderful mother. She really wanted to have a baby. She created the best possible village. She had the best possible insurance. She had the best possible education. She did everything she was supposed to. She had a number of complications, of risk factors. But she came, again, like so many women who are on it and whose doctors are on it, she came through pregnancy and her childbirth really okay. It was the postpartum period that failed her, and she kept going back over and over. She kept developing one complication after another, and she kept going back, and her mother kept going back, and they took the baby, and everybody knew, and she had the best doctors, and they were so thoughtful and caring, and yet everybody kept sending her home. They kept saying, well, there's nothing, it doesn't fit any boxes, and therefore there's nothing the matter with you. And they told that to her for a couple of weeks until finally her last day, she went to the doctor and they sent her home again, and she died that evening. She collapsed that evening, and she died 2 or 3 days later. And I think that sort of understanding kind of this idea is, how could this happen? We think about maternal death as being something that happens to other people. We think about it as being something that's very tied to maybe to class, if not, if not race, race and class. And we don't think of Shalon Irving as being the person who would be at risk. But the fact that somebody like Shalon Irving, that happened to her and to her family, I think tells us really how profoundly broken the system is for African American mothers in particular, but also for all women. The what happened to Shalon has happened to many, many, many women that I have, whose stories we've heard and examined. So it happened to her. It's yeah.
Thank you. Jenny, you want to
Yes,
follow
I
up?
would like to just point out as an example of a glaring flaw in maternity care, and an example then of how we are accepting of it's been like this. So there is no postpartum care in the United States of America. I'm just going to say that out loud. Okay, postpartum care does not exist. Why? Because as the baby is born, the obstetric episode, so it ends. That's time to bill. Here's the code. You're good to go. Baby's out. So other than having a couple of days in a hospital where you're relegated now to the postpartum floor, rightly so, but no one manages that shop the same way, because your private practice physician or your clinician at the outside of the hospital clinic has no real connection there any longer. Once you leave that hospital, 2 days postpartum, 3 days postpartum, you're on your own. No one's coming. You may have a 6-week postpartum appointment if you're very lucky, but you may not. So in the interim, you're left wandering the streets. You'll find yourself in the emergency room. You don't get readmitted to labor and delivery. That code is long gone. So we have these ridiculous and bureaucratic disconnects that we've accepted as this is how we do it. Therefore, it's not going to change. But unless we recognize the areas of these glaring gaps and these disconnected silos, we have left American women bereft. They are fending for themselves. The emergency rooms do not provide obstetric care. They may call an obstetrician in, but with a reluctance, with oh, here she is again. Like, there's not a, we got you. We recognize we're it for you. This is what we're here to do for you. None of that. So the majority of the morbidity and mortality falls into that massive chasm, which is a dearth of postpartum care and support or interest for women once the baby is born.
The other thing about Shalon's story, I think that's important, is that, well, two things. First of all, we discovered as we were doing our work, we were looking very hard for African American women and families to talk to. And it was really hard because women and families did not want to talk to us. They didn't want to participate in our research. They did not feel able to sort of talk about incredibly difficult private and often things that might leave them open to stigmatization and pain in the ways that many of the Caucasian or other women who reached out to us and their families did. So what was different about Shalon was that she was a researcher, and her parents understood. Her mother in particular understood, and her mother was so brave in the middle of the worst possible grief that you could ever imagine going through. Her mother was so brave to talk to us again and again and again, and to let us tell that story, to trust us to tell that story. And I think that that we were able to tell the story the way that we did was really as much more reflection of Wanda Irving's willingness to go there with us than ours to sort of to handle that material and to sort of tell her story in that way. The other thing that Shalon's story also raises is sort of the long-term impact of discrimination, right? So we know sort of the ways that sort of stress and discrimination constant, even for affluent and well-educated African American women, maybe even more so for affluent and well-educated American women, African American women takes a huge toll, physical toll, that we have only really started to think about and try to understand, and that can make pregnancy and childbirth and the postpartum period more complicated than it might otherwise be.
I want to ask a follow up on that particular issue, particularly the stress, and I think also the wear and tear, not only physically but also mentally, that it can impose, on a woman, particularly in the postpartum period. And sort of what we know about access to mental health care is that for women of color, they are least likely to know the symptoms of mental health conditions that they could be undergoing, as well as have access to the care and treatment that they need. And so what can we do to help ensure that women have better access to mental health care, particularly in the postpartum period?
I would say the same thing that we are doing or trying to do for the prenatal, which is provide accessible, I say, entry-level, paraprofessional women, men who are actually there. So I'm not going to live in a Pollyanna world in the hope that the mental health providers will come running, right? But in the meantime, listening is so powerful. Peer level behavioral health support is really important. And just asking, how you're doing is a big help for women in these situations. My thinking is that at least initially, that we get on the ground the home visitors, the texters, the phone call makers who are simply asking, are you okay? And then having real resources on the other end of that with, oh, let's help you get to A, B, or C provider or practice or agency right now, because we are going to help handhold you right in the door so that you get those services that you actually need.
And I would love to add I think the importance again of the intersectionality of this issue, when we know something Nina said about women may not go and take care of themselves, but they will go and take care of their baby. And so we know that women will go to a well baby visit when the baby's an infant, and that is an excellent opportunity to do exactly that, right? To have a maternal depression screen in the pediatric office, because we know mom is going to show up there. So let's actually address both needs. And then likewise, something that we focus on a lot at 0 to 3, the paid family medical leave time. Again, you have time for a parent to actually take stock of how they're feeling. And if you have that connection, then they're actually not going to work 10 days after the baby's born. They're able to go to the baby well visit and get linked up to somebody. And then they can actually access their medical, take care of their medical needs, their mental health needs, and not worry about missing a day of work. So that's also really important. The last thing I'll say, again, the intersectionality is of infant early childhood mental health. So this is something we focus on a lot at 0 to 3, is that thinking about how the environment, the stress of the home also has an impact on baby's mental health. And if baby is not doing well, then mom is also going to struggle. And so again, thinking about the holistic policy, solutions, the practice solutions, and thinking about this in the same way that families think about it. They don't disassociate themselves from their child, and the child doesn't disassociate herself from her mother. And we need to be thinking about that from a policy and a practice perspective.
Brianna?
Really quickly, I just wanted to add, so I know at the state level we've seen several proposed bills expanding access to mental health services in the postpartum period, and I think that's great. But two things. To your point, we have to acknowledge the fact that, particularly for Black women that have this chronic exposure to stress, we need access to those mental health services outside of just within the context of pregnancy. And so when we expand mental health services, it just needs to be in general. We just all need access to mental health services. A lot of those bills are focused primarily on Medicaid, but what about women with private insurance?
Right.
That's important. And then regardless of the coverage, we need to make sure that it's affordable. So even if it's covered by my insurance, to what level am I still able to have multiple visits with a provider if I need to? And then also making sure that we have the providers available to actually provide the services. And so I think that as we're talking about expanding care, we really have to look at it from all angles to make sure that we're not implementing policies that then no one can utilize.
If I could just add, making sure that the providers, and this is true in the maternal space, general mental health, but also in the infant early childhood mental health space, they look like the families that they serve.
Absolutely. That's a huge problem. I know that we want to get to Q&A. I do have one more question for my panelists. Um, and basically this conversation today has really been about, how we move from dialogue to action, particularly in the context of policy solutions. In the 2018 midterms, we saw candidates run on this issue, from Beto O'Rourke, who talked about it in the media, as well as he penned an op-ed for Essence Magazine, and Stacey Abrams also included this as part of her platform. How do we move ahead? Now it's time for action on this issue, particularly from policymakers, and then also how do we hold them accountable?
I think it's a great question. And I think, to your point, there is a lot of attention on the issue right now. What I'm finding is still missing is the inclusion of Black women in the conversation. Unfortunately, a lot of the rooms that I sit in don't look like this, where we have a diverse panel. And so I think that that's the first step, is to make sure that as we have this heightened awareness of the issue, is that we're holding systems and governments accountable to make sure that Black women are at the center of those conversations. And there's a lot of entry points for that. So we have a record number of states that have established maternal mortality review committees, yet a lot of those committees are not diverse. You don't have a diverse representation of providers at the tables to discuss it. You have no community representation there. And so you're only looking at a very limited focus of the clinical outcomes of that pregnancy, instead of really incorporating the social, contextual issues surrounding why that mom lost her life. Additionally, when we think about the funding, so you have this, everyone wants to do something about maternal mortality. So some states, and even at the federal level, they're allocating funding to it. Well, to what extent are community-based person of color-led organizations even eligible for that funding? How do we write that into the policies to make sure that we are not excluding organizations that are already doing the work from being eligible to receive the funding and continue to sustain their practices? So there's a lot that can be done that I think is still being overlooked, and we can hold our governments accountable by continuing to raise that issue to them.
Outstanding, Brianna, of course. Any other thoughts on that piece, how we move forward?
I would say I'm very hopeful about this, the 116th Congress. This is a huge opportunity for education, right? So those of us who are advocates, who lead policy organizations, this is an opportunity to go in and inform them, educate them, make them champions, cultivate champions. It's not enough to have two candidates, who I won't say unfortunately, we are nonpartisan, but two candidates who did not prevail. We need to have folks who are in the decision-making seat right now, clearly engaged and committed to this work. I will say I'm really hopeful about paid family medical leave. I think this is, again, talking about the postpartum period, when we have women who are going back to work after 10 days of giving birth, the chances that those women who've had complications during pregnancy are going to do well when they're standing on their feet or even sitting at their desk is really not great. So we are leading to that complication if we don't have a paid family medical leave. And I will say, ironically, I was surprised by this. A couple months ago, the Bipartisan Policy Center had a forum, and I found myself having breakfast with Ivanka Trump, Senator Chris Dodd, who is the architect of Family Medical Leave, FMLA, that we currently have, and then former Senator Rick Santorum, who was a major opposition leader against that. And we were all talking about the importance of paid family medical leave. Now, again, it was the pay for was up for grabs. There are a lot of details that still need to be ironed out, but this is really getting bipartisan traction. And I think, again, we need to cultivate those leaders to be supporting us. I would also say I think mental health is a really exciting place for us to be right now, those of us who are tracking federal policy and thinking about these issues. So those are the ones I'm very hopeful for, and I think they have an impact, especially in the postpartum space.
And I'll just add too, there have been a lot of bills introduced on this issue in the last year or so. I mean, based on the work that CAP, the women's team in particular, has done, we've counted over 20 bills introduced in this space. I will say that a very small proportion of those bills center women of color and Black women in particular. So in terms of the conversation and recognizing that there is some bipartisan interest, I think in order for these proposals or policies to work, they do need to center women of color, particularly Black women, when we're talking about the solutions. And then Nina?
One thing I would like to say, I think that is really sadly lacking in all of our conversations is a mechanism for women to speak about their experiences, especially when they've been mistreated. I think that one of the things that I hear over and over again from women of every class and every level of engagement around this issue, especially women of color, is, well, yeah, I had this terrible experience, but I didn't talk about it to the people because I didn't feel I would be listened to, because there was no mechanism to do that. And so I think that actually figuring out a way where we've activated women, which is amazing, to push forward so much of this legislation and change and everything. We'll be talking and thinking about this, but also to giving women a way to thinking about how to allow individual women and families to be more part of the process of really holding bad actors accountable, I think would be amazing. And that hasn't really been part of the conversation yet, but I think really needs to be in order for true change to happen at a local level.
Thank you. And so now we're going to shift to Q&A. We only have time for a couple of questions, unfortunately. I saw this gentleman in the back here with his hand up first.
My name is Eric Garvan, and I do consulting work on future technologies, but I'm also a father, and I have a question. First, I think the system is working perfectly. I don't think there's any mix-up. I think it's intentional. Everything is working great. An implicit bias. How am I, as a father, erased from the conversation? It's happening now. Okay, and a question that I have 3 children, and all 3 of them were difficult births. I mean, laser laparoscopies, uterine resuspensions, all this kind of stuff. Okay, how do I assert myself in this environment? What suggestions do you have that a man can assert himself as a father when he is with the mother? It has often been assumed that we weren't married. It was assumed that I was a drug addict. It was just amazing, some of the and I'm a well-educated person, and fortunately we had resources. I have no idea what other people are dealing with. But I'm curious, any suggestions that you have as a man, what we can do to assert ourselves in this conversation?
Well, first I'll say thank you so much for that question. I do think it's interesting that you said you don't see any issues with the system as a man. The system is working perfectly for you as designed? Okay. Just wanted to make sure I understood that. Okay, got it. Okay. So does anyone want to answer the question about, how we need to be more intentional about including men in the conversation, and also in the role of the care of, of their partner or their wife?
I mean, I'll just say I think the fact that you're present is great. I think being a support to the woman is great. I know many of you may have heard the story of Charles Johnson, who has talked about his wife, Kira Dixon Johnson, who died in the hours, I think, after childbirth. And so he attempted to assert himself. And sadly, him asking several times what's happening with my wife, what's going on with my wife, it didn't work in that particular situation. But I think we have to continue to assert ourselves in that manner and continue to interject ourselves. And he has gone on to be a great advocate for this issue. And so while I don't have any specific advice for you in that way, I think the more voices we have around this issue can only help us continue to amplify it. And we need everyone, not just Black women, to help lift up this issue. So Black men, all of our other allies, everyone else, we need you here for the conversation.
Jenny, did you have anything
Yes,
to add?
just very quickly. The fact is we've been working towards what we call mother-baby in terms of understanding the mother-baby connection. For example, skin-to-skin care is becoming much more a standard way of being. Babies born and put on mother's chest immediately. So mother-baby as a concept has grown over the last 10 years. We can stand for mother-baby family, right? That's a, you know, the however many are in that group stand as one, and that we as providers and agencies recognize it as one. And that's something that we have to do as we do our implicit bias training and our new ways of thinking around this. This is going to be brand new thinking for America. It's not something that's there now. So it needs to happen, and it's important to keep speaking about it. But I think it comes from recognizing that this woman who's having the child has a support group and is connected in this way, and this is one unit.
Looks like we have one here, and then we might have time for one more.
Hello, my name is Shannon Lee. I write for the Lily at the Washington Post, and I worked on a recent study or digital report that came out by Merck for Mothers, and I was able to interview some researchers who work up at Columbia University, and that was something that I didn't hear a whole lot of on this panel in terms of what's actually going on and what's being introduced by way of research and the research that needs to be funded, because the report basically addressed not only maternal mortality, but it also addressed disabilities that incur. And there's such a large number of women who are actually going home, who are not, the worst case scenario is death, but there's also thousands of women that are going home every year after birth that are disabled, that are not able to return to work, that might not even be able to take care of their child once they have it. And so we know that there is such a gap in not only services, but also, who is not benefiting from current health care, who is, what's happening in terms of, I'm sorry, I just lost it for a moment, but, it all starts with research, because a lot of the stuff is preventable. So I just wanted to hear from you, and especially everyone that's everybody that's researching this issue and working in the healthcare space, what is being talked about in terms of research that needs to be funded and new research that's come about recently?
Brianna wants to start.
Sure. So yes, to your point, I do think it's important to lift up that maternal morbidity is 100 times more common than maternal mortality. So for every woman that dies, we're seeing 100 more that experience a severe maternal morbidity. So research, I won't get, in the interest of time, go into like the details of what type of research we need, but we do need more of it. But most importantly, what we need is community participatory based research. So we don't need people coming in and doing research on Black communities. We need people doing research with Black communities. And we need to allow Black communities to identify what research is needed to help drive the policy and advocacy that we want to do within our communities. And so I think the Columbia group, the Averting Maternal Deaths and Disabilities group, did work very closely with the Black Mamas Matter Alliance to do some research in Atlanta. They also did it in New York City. And so we need more of that collaborative research to help us identify where the gaps in care are and where the opportunities are for improved care.
We also need to fund Black researchers as well. That's not to say that, we can't have others come into communities and do that research, but a big, we have researchers, Black researchers, that are really thinking through this issue in a substantive way, and they want to do the work, but they are underfunded. So that's also a big piece of the research, what we need in terms of the research piece. Anything else?
Quickly, I think it's important to talk about the evidence-based outrage. We have enough evidence already. We need more, of course, but at the end of the day, where's the outrage when we finish these studies?
I would argue too. I mean, in terms of, we talked a lot about the postpartum period. And so I think it would be useful to have more research in terms of, having conversations with women, both qualitative and qualitative research, quantitative and qualitative. So doing some story collection, similar to the great work that Nina has done, to also get a sense of what women's needs are in the postpartum period, as well as the whole family. I think that we are done with the questions. And we'll hang back a little bit if folks want to talk to us directly. But I want to thank you all so much for being here. I do want to acknowledge the Goldman Foundation for supporting CAP's work in this space. This is a complex issue, and this is one of many conversations that we will have, in this space. But I do hope that you all leave here today empowered and encouraged to lend your voice to eliminating maternal and infant mortality. Thank you all so much.